of the organism is Streptococcus pyogenes, which we'll talk a little more about later. But it was a 6-year-old boy. He had a fever of 102. They gave him acetaminophen. He had a rash on the tonsils. Diagnosis was scarlet fever based on the observations that they took. And typically with Streptococcus pyogenes infections, a lot of times the rash and spots on the tonsils, a lot of times that evolves from a strep throat infection. It's Monday. Sometimes I can't spit it all out on Monday. But usually that comes from a strep throat infection that has been prolonged for a long period of time. A lot of these things are complications due to not treating that strep throat infection. So the rash and spots, it could be because of a prolonged infection, but I didn't quite get the full background of this particular study. The treatment, typically they like to use penicillin, which not a lot of things respond to penicillin. But if you do have a Streptococcus pyogenes infection, if you got strep throat, they would like to use penicillin, although a lot of people are allergic to penicillin, so they give alternate things, erythromycin, variety of those types of antibiotics that they use. They probably even used
They're using Keflex now too.
Keflex, yeah.
And there was one they gave my daughter a couple streps ago. It was like $200, and I can't think of the name of it. And it don't come in generic.
Yeah, there's a couple of really expensive ones that are crazy, but they work.
Well, I asked the pharmacist, I'm like, is there nothing cheaper that they could have gave her? And they're like, oh yeah, penicillin, amoxicillin.
She's
I'm
not
like,
allergic to it.
$200 versus $4.
Yeah, they must have had some drug company come by and try to push it in there.
Oh, yeah.
Yeah, some of that stuff's all.
Yeah, I was not too happy.
I hate when they try to prescribe the same drug for everything just because they're pushing something for a company. Like, really? Are you kidding?
Yeah.
A lot of times, if it's newer, insurance doesn't cover very much of it.
Yeah.
As far as pharmacology, you guys don't have to know that definition, chemotherapeutic agents. And I think you guys know the different types of antimicrobials as far as categories they can fall under. But the one thing on the slide I want to point out is what an antibiotic is. And that is a metabolic byproduct of a microorganism. So for instance, penicillium, a fungus, produced penicillin. Now, we alter a lot of these drugs, so there's somewhat semi-synthetic versions of them, and kind of alter them as much as we possibly can to keep certain drugs, especially in use. Drug administration, I don't have to go through this with you guys. We're not. Barriers to drug distribution. Anything I can cut, I will. 2 barriers that I want you guys to know. The cell membrane. So the cell membrane just being that those components, remember the phospholipid bilayer, you have a hydrophilic portion and a hydrophobic portion. So drugs that can dissolve in phospholipids would pass right through. Ones that would be more hydrophilic in nature would need some type of protein channel to get inside the cell. Now, as far as CNS and eye infections, those are very hard to treat due to the membranes around them. The second barrier would be proteins that bind to drugs, and they just form a protein drug complex. And in that form, they cannot pass through the membranes. But now, it's not permanent, so what happens is some of that drug is released, and then another will bind, and then some of it's released, and then more will bind. So all it does is slow down the distribution of the drug. And this is just a summary again of what I just said. As far as methods of elimination, again, I'm probably not going to ask you this on the test. I know this part they do go over in Pharm can be metabolically converted to something else, and also exiting the body, like in the urine, secreted in the bile, feces, all of those methods. Selective toxicity, probably won't ask that either, but again, this is concerning the selection of the actual drug that you would use. So you want to inhibit or kill the microorganism, but you don't want to do harm to the human cell. So you want to target the right cell with minimal side effects to our cells in the process. And it ends up becoming a little bit more of a challenge when you get into periodic infections such as fungal infections and parasitic infections. Of course, that side effect statement, you guys know that danger must be weighed against the benefit. As far as drug resistance goes, first let me talk about this chart. It's not in your book, but just to refresh your all's memory here, a narrow spectrum drug versus a broad spectrum. I'm not going to ask these, I just want to show you some examples here, like penicillin. Penicillin is effective for gram positives. So this is the particular group that that drug would target. Now there's certain other types like gram negatives, positives, rickettsia, chlamydia. They try to put in their own category. Mycobacteria such as tuberculosis or leprosy gets its own category as well. So things that are narrow would just hit one of these groups, as things that are broad would stretch across a couple. Now, as far as natural resistance goes, sometimes the species just lacks the target that the drug would bind to. So it wouldn't get in the cell, and therefore it wouldn't be effective. Now, acquired resistance could be something like mutations or genetic exchanges, going back to that conjugation with the sex pillus that we talked about in chapter 4. Gram negatives can transfer plasmids, and that's their conjugation. And those plasmids encode for some type of resistance factor. Especially drug resistance is one of those common things that can be exchanged. But one of the things that they might do is acquire the ability to make an enzyme that would break down that antibiotic. So this term beta-lactamase, I want you to know, a lot of times they call those penicillinases, but beta-lactamase is the term that I use on tests. I'm sorry there's so many different names for things, it just kind of is. Penicillinase is more of a generic, but I guess beta-lactamase is as well. But beta-lactamase, penicillin itself has a structure called beta-lactam ring. And what that enzyme does is break that structure down. So penicillin is no longer penicillin. Also, another thing that can happen is they can change the cellular target on which the drug acts. So you can have a change in, for instance, the penicillin binding protein, which means that it would be less able to bind and less able to get inside the cell. So those mutations, for instance, if it altered an amino acid, it would change the protein structure. So there's a lot of little itty-bitty details here. You can prevent the entry or pump the drug out, and they do that by using a transport system, which is a protein that is inside the membrane. So there are some organisms that can send the drug right back out when it goes in. Now, you guys understand that a lot of these infections that we have are normal flora were just opportunistic normal flora. So given the opportunity, they overgrew. Now, a lot of infections are from outside sources, but especially when you have normal flora, such as if strep pyogenes is incorporated into your normal flora, you get strep throat all the time, taking the same drug, sometimes that organism can get resistant, and it's by certain methods that I mentioned. As far as strep pyogenes and plasmid exchange, it's a gram positive, so the odds of that happening are slim to none, but mutations could occur as well. So there are different ways that the organism could become resistant to that particular antibiotic. Now, there are organisms that, especially things like gonorrhea, which is not normal flora, but have become resistant to a variety of antibiotics because they have been used so much. So those particular strains just exist, and as they're passed on from person to person, they have gained that resistance based on being bombarded with a certain antibiotic over and over again. This is just a little more on that beta-lactamase enzyme. So it would target the beta-lactam ring structure in penicillin, and it would prevent penicillin from doing its job. And penicillin's job is to block cell wall synthesis. This is just a summary there of resistance. Slowing resistance, of course, reducing non-essential medical use of antibiotics. A lot of times there are physicians that will hand out antibiotics like candy when that really wasn't what was needed for that particular case. Combined therapy is used quite a bit too, where they will combine antibiotics together, especially to reintroduce some of the old ones.
Now, what about if they use an antibiotic, say like microbit, for UTIs, for prophylactic? Won't that eventually not work anymore? It seems like pointless to.
And they do that too with some of the sulfa drugs, especially people that get a lot of UTIs. They will use a lower dose, but like one a day or something for a prophylactic. Yeah. Technically, you would have the ability, your organisms would have the ability, especially if it's one of those things that are normal flora that goes from one area to the other, or a variety of other reasons why it would, but it could still be normal flora that you come in contact with. You could possibly, those organisms could get used to it. Yeah, so I think for short term that works. Short, long, but it 10, 15, 20 years down the road, it's not such a good idea. And that antibiotic may be completely useless. Now, as far as doing that antibiotic susceptibility test, technically that's called the Kirby-Bauer method. And I've already went through this particular setup with you, where you cover the plate with the organism, place the discs on there, incubate, and then you measure the zones of inhibition to find out if the organism is sensitive, intermediate, or resistant to the antibiotic. And remember that zone of inhibition, it'll stay away from the actual drug. We can skip through this particular slide. Don't ask those on the test. There are other methods not as commonly used. Targets for antimicrobial drugs. You don't have this particular picture, but that's okay because I go through all of this with you for the drugs that you need to know. But I want you to know the targets for prokaryotic cells. The first one is cell wall synthesis. So considering we don't have a cell wall, this is a great target for prokaryotic cells. So those drugs will destroy the peptidoglycan and prevent the synthesis of, especially good for gram-positives. You can also have drugs that will target the cell membrane. Polymyxin B is one of those. You can see a bunch under the cell wall inhibitors there. Nucleic acid synthesis, there's some that target RNA synthesis and some that target DNA. As far as those particular drugs, they'll target enzymes that are unique to prokaryotic cells. Now, protein synthesis and folic acid synthesis, I call folic acid synthesis metabolism there. But protein synthesis, remember our ribosome sizes are different. Prokaryotic cells have that 70 Svedberg measurement, whereas we have the 80 Svedberg measurement. So as far as the prokaryotic cells, protein production would be affected in those cells, but not in our cells. So this is a really good picture here showing a couple of different antibiotics. For instance, chloramphenicol inhibits that peptide bond formation. So if you're inhibiting peptide bond formation, those amino acids can't link together to make the protein. Tetracycline prevents that transfer RNA from entering. Certain antibiotics will bind to the actual ribosome, and you can make faulty proteins that don't really work, or it can stop that process altogether. Now, metabolism, that's the last target, or interfering with folic acid synthesis. That's all you got to know there. Again, a summary of the sizes of the ribosome. Remember, the overall evaluation is 70 Svedbergs compared to the eukaryote, which is 80. The large and the prokaryote is 50. The small subunit is 30. Compared to a eukaryote at 60 and 40. So either way, those antibiotics would not interfere with our protein production. Now, eukaryotic cells, there's just a couple of targets here: the cell membrane, nucleic acid synthesis, and folic acid synthesis. And they find a target that is unique to that particular microorganism. Okay, so going on to these drugs. Again, I will mention everything on these slides that you need to know, so make sure you highlight them. A lot of times I do multiple choice questions, but then sometimes I'll do matching. So that's the kind of questions that you're going to get out of this information. The first drug is penicillin. You need to know what it does. It inhibits cell wall synthesis. So this particular drug is good for gram-positive cells. You do not have to know the source. The source, it is an antibiotic form naturally produced by a microorganism. And then there are semi-synthetics where we have chemically changed certain portions of it just to modify it a little bit. Another thing I want to point out of these particular groups, that ampicillin is a relatively broad spectrum in this particular category. Right, moving on to the cephalosporins. They also target cell wall synthesis, and they are effective for gram-positive cells. And the higher the generation, they become more effective for gram-negative cells. Again, don't worry about the source. But now the one thing that's very nice about this particular drug is that if an organism has this enzyme beta-lactamase, even though cephalosporins have a beta-lactam ring, it is less likely that they will break this down than the penicillins. So this particular drug is more resistant to beta-lactamases. So if you know that you have a microorganism that is resistant to penicillin, this would be a better drug to use. Now, as far as the first generation, I gave this example because it's very commonly used, Keflex. Fourth generation, I don't think your textbook has it in there. That's typically an IV type of drug. The sulfa drugs. These were the first antimicrobials. They are less effective now because they have been used so much, so there is a lot of resistance to them. They are typically combined with something, so they are used in combination. This sulfamethoxazole trimethoprim, that's that Bactrim or Septra that's used a lot. What this one does is target metabolism or inhibits folic acid synthesis. There's a lot of allergies to sulfa drugs. Sulfa drugs are kind of rough sometimes. That will probably kill me the next time I take a sulfa drug, so I'm not real big on those little guys. Chloramphenicol. Chloramphenicol is a broad spectrum antibiotic. Now this little guy can penetrate the CNS and the interior of the eye, so it can go places normally that drugs would not be able to go. It is good for gram positives. It's good for gram negatives. Even the rickettsia and chlamydias, they can be killed or treated by this particular antibiotic. Mycoplasmas that cause walking pneumonia, they can be targeted by chloramphenicol. So this drug has a wide variety that it can actually target, and what it does is it targets protein synthesis by inhibiting the peptide bond formation, which I mentioned earlier. So that bond does not form between the amino acids. Now, as far as whether this drug is used a lot, it's not really used a lot because it is associated with really severe side effects. The one that I want you to know is aplastic anemia, and that's where the bone marrow would stop producing blood cells. And that's a pretty big problem. So this is not something that you guys will hear commonly used at all.
Will they use it in combination with chemotherapy to wipe out some of the bone marrow?
I have not heard that they do that, but I mean, that's interesting. I haven't heard that they use chloramphenicol.
Pipe is not.
But now
Every
sometimes,
time. It's how they-
yeah, sometimes they use unconventional drugs though that wouldn't typically be used for something for it because it does do. But this is one, and I don't know what the percentages are, but the odds of that actually happening. So yeah, I mean, it's a shot in the dark. So I haven't really seen any literature that uses that. But
What is gray baby syndrome?
as far as some of the toxicity that the baby, I can't remember all of the different, whether they get neurodegenerative abnormalities. I have to look that one back up. I don't remember it off the top of my head. Or if they just can't process the drug and they end up dying from those types of complications of not actually, it just building up in their system. Can't remember which one it is.
Oh, it's not.
Off the top of my head, yeah. Why don't you look it up? And you know, I'm that was one of those things that I used to know a little bit more about. But the older I get, the more I just kind of lose some of that stuff. That I haven't heard of it in a long time, and that's one of the reasons why I stopped addressing it. But you guys are in peds right now, aren't you? Yeah. Ask about that and then tell me. I think they can't process it, but I can't remember all the tissues that it goes into. So, I'll stop there.
I'll look it up.
As far as the tetracyclines, a lot of these are considered broad spectrum. There's still not a lot of stuff in it, but it does do a wide variety of groups. It's not that great though for some things. As far as the action, it will block transfer RNA from entering the ribosome, so it targets protein synthesis. A lot of times they used to use it for acne, and now they've kind of went to a doxycycline and a minocycline. It's changed just a little bit, but I'm sure as far as pictures of the teeth, you've seen those with children that have used tetracycline, and it's not for all groups there. Aminoglycosides, example, no streptomycin, typically more effective for gram negatives. It is one of those protein synthesis inhibitor groups, and most of the time they'll use E. coli for all this stuff. So when I say E. coli, it's just because that's the organism that it was studied in. But it binds to the small subunit of the ribosome. So it interferes with protein synthesis in that manner. As far as limited use, it can damage the inner ear, and there is a lot of microbial resistance to it. Erythromycin in the macrolide family. It is relatively broad. There's some textbooks that only put down that it's good for gram positives, but it does cover some negatives too. Typically used to treat strep throat and respiratory infections. Pretty cheap drug now. This one binds to the large subunit of the ribosome, so the 50. So again, it targets protein synthesis. The quinolones, these are broad spectrum. Fewer side effects, a little less drug resistance, and this one interferes with DNA replication. You don't have to know topoisomerase. That was one of those enzymes that we had in that chart that I didn't have you know, but it targets DNA synthesis. Cipro is your example there. All right, as far as mycobacterial organisms, these guys tend to be a little more difficult to treat because they've got a little different components in their cell wall. That mycolic acid layer that you find in the cell wall of these organisms cause a lot of resistance, especially to drugs. It grows very slowly, so it is hard to diagnose sometimes. A lot of antibiotic resistance because the therapy is a longer time period, and if those drugs are not used effectively in combination for that period of time, the organisms become resistant to certain components of that therapy. It is an intracellular pathogen, so the drugs have to enter the human cell to get to it. So it tends to be a little more complex. The isoniazid, I would like you to know, that is bacteriostatic for resting cells and cidal for growing cells. The rifampin, I don't ask you this a lot of times, but it does target RNA synthesis. And ethambutol, which inhibits the incorporation of that mycolic acid. So all the drugs kind of have their job. So that's why in combination they best work all together for an extended period of time. All right, going to the eukaryotic organisms, those cells are very similar to human cells. Not as many of these drugs as it seems that there are a lot of the prokaryotes, but looking at some of the antifungals, nystatin, all you got to know there is it targets the cytoplasmic membrane. Imidazoles, it inhibits the sterile synthesis in the membrane, so again, cytoplasmic membrane. Amphotericin B, on the next page again, disrupts the cytoplasmic membrane. Flucytosine, which is a synthetic pyrimidine analog. Does anybody know what that means? What's a pyrimidine? Purine and a pyrimidine. Remember those components of a nucleotide?
Is it the base?
Yeah, it's one of those bases. So that targets more so nucleic acid synthesis. Griseofulvin. This is typically used for ringworm infections, and it prevents cell division. Some of these antiparasitics, mebendazole, that one interferes with glucose uptake. And I want you to know the typical treatment for roundworm and tapeworm infections. Metronidazole or Flagyl, good for protozoal parasites. Uses cell energy or robs reducing power. Typical treatments are protozoal infections, but it has been used for a lot of other things. So don't want to, but I got to ask you what they say in the textbooks. Chloroquine, it's an anti-malarial. There's quite a bit of resistance, so it's not just some anymore, quite a bit of resistance to it. Not a very good drug anymore. As far as mechanisms, protein synthesis has been one. They've kind of played around with a lot of different things that it can actually do. We'll just keep unknown mechanism there. As far as the antivirals are very few. It is hard to target that virus without targeting the host cell. Because remember, that virus does not do anything until it gets inside and takes over our machinery. So ends up being a little difficult. Manstein, that one's good for influenza A virus. It interferes with viral replication. Acyclovir, good for the herpes viruses. It is a guanosine nucleoside analog, so it interferes with DNA synthesis. Ribavirin is a guanine nucleoside analog, and that one interferes with RNA synthesis. And then the anti-HIV agents, you do not have to know the examples of these. But in that combo therapy, you have reverse transcriptase inhibitors, and that's targeting that RNA becoming DNA and then getting incorporated into our genome. So that reverse transcriptase inhibitors is inhibiting that RNA to become DNA. And then protease inhibitors, which is interfering with some of those proteins that the viruses make. You don't have to, there's a long list of those. You don't have to know any of those specifics. And then you guys can